y'all know astrology. So these are the topics we're talking about today. Actinic keratoses, or AKs. The seborrheic keratoses, those are the benign ones. So that's actually a benign disorder. Those are SKs. And then basal cells, BCCs, squamous cells, SCCs, and Kaposi sarcomas, and then melanoma. So I just put the abbreviations because that's what you will commonly see in charts, is the abbreviation, because it takes too long to write everything else out. So the first ones are AKs. And everybody has grandparents or older people that they're around. Anybody has someone who worked on a farm. You know, if you looked at your grandparents, if they were out a lot when they were younger, most likely every one of them will have at least one or two of these AKs. So what are actinic keratoses? So these are what we call precancerous lesions. These, I feel like, are better felt than seen. Now some people, you can actually see them outright, but these will have kind of like a scaly look to them. But these, what you worry about them is that they can turn into more advanced disease, which is the squamous cell carcinomas. So AKs, if you see them, you should have them treated so they don't progress. Okay. Like I said, 10% risk of malignant transformation into squamous cell carcinomas. Yeah, like I said, it's most commonly, you'll see this in practice, you'll see it in your family members. Your grandpa will ask you what this is, and you're like, it's an AK. So today, well, after here, I want you guys to find someone old and look at their face, and look at their hands, feel them, and you're like, oh, those were AKs. Because the more you see, the more you feel, the more comfortable you will become with your diagnosis. So, who gets them? So with the AKs, with the skin cancers, it's all the same people. So the very fair-skinned, those who work outdoors, those who are out in the sun a lot when they're younger, those are all at risk. The fair-skinned, blue-eyed, blonde hairs, I see a lot of you all in this room. You guys are at high risk. Not to say that, you know, I'm not at risk, but I'm at risk of more of the scary ones. But you guys are the most common ones you'll see every day is the fair-skinned. You guys already learned about the Fitzpatrick types, right? So 1 and 2s. AKs, again, usually sun-exposed areas, your skin, your head, your ears, your arms, your legs, not so commonly. I saw more on the head. So people, bald men, tons of them on their heads because they don't like to wear ball caps or hats of any sort. Usually, again, middle-aged, elderly, males, it's more common in men. You'll see them a lot in grandpas, or because they were all the ones working out in the farms, you know. So, like I said, these, you can feel them better than you can see them. So with dermatology, you have to feel, you have to touch your patient. Like if someone goes, hey, what's this on my face? First thing you're going to want to do is you're going to touch it. You're going to feel for it, feel it scaly, if it's you know, then you characterize the morphology. Is it a papule? Is it a nodule? Is it a plaque? But these will kind of feel gritty, sandpapery, just really rough on the skin. So how many have grandparents have you seen things like this on them? So the typical ones that I usually see is that top right, that kind of scaly, yellowy, really thick in the hands. I would see in internal medicine, I'd see tons of those hands. You need to feel them, and they're just like all bumpy on the top of their hands. And then the men, right there, the little bald man. You bring it, you know, it doesn't look as bumpy, but if you put your hand across his forehead or his head, it would be all nice and bumpy. And these are horns. These are actinic horns. And you will see these, you know, but you will see them. And at the bottom lip, that is actinic cheilitis. So that's a precancerous on the lower lip. You'll want to treat those as well, because you don't want that to become an invasive squamous cell on their lower lip, which is very common. We used to see that all the time. You know, people are out in the lake, they forget to put sunblock on their lips or put anything on their lips. And that's why when you go out from the lake and you come back in, your lips really burnt, hurt. So how do you diagnose someone with an AK? Again, it's usually physical exam. Generally, I never biopsy these AKs because once you see one, once you feel one and see them, you'll know that it's an AK. You can biopsy it, but again, it's really never done. You can do a fluorescence with a Woods lamp if you're concerned it might be something else. So if it's, these AKs tend to persist, they tend to grow. I've never seen them spontaneously regress, but I'm assuming they could. The only time they become tender and thick is when they start progressing to an SCC. These are other differential diagnosis things they can look like. Psoriasis, they kind of look like, because it's got that red base and the thickened plaques. And then Lichen Planus. Have you guys learned about Lichen Planus yet? I don't feel like sometimes it really looks so much like a Lichen Planus, just because that lichen really has that white, lacy pattern to it. But in irritated seborrheic keratosis, a lot of times those can get really inflamed and thickened and kind of look like that. And then how do you treat these AKs? The majority of the time, you're going to freeze them off. So if they go either in your clinic, if you actually happen to have liquid nitrogen, you can freeze them off. You can do an electrodesiccation, so taking little bovie and burning them off that way. But most of the time, they are treated with cryotherapy. Now you can use something called 5-FU. Have you guys talked about that? Have you had pharmacology yet for the medications? So 5-FU and Aldara are creams that you can put. So if someone has, like someone with it on the forehead or on the scalp, tons of little lesions, instead of freezing them all off, you can use creams to put across them. I would see a lot on people with multiple lesions on their face. You can use the Aldara cream. And there's something new called Picado, which I've never used. This is just a gel versus a cream. But Aldara, if you've ever seen anybody use it, it'll burn. It looks like they burn their face off. I saw something just recently on. You guys follow medical people on Instagram? So I think it was like medical pictures. This was the big thing that you would see, and especially from people with from small towns. They would get this black salve, and everybody will say, "I use a black salve," and they'll put it when they have precancerous lesions like that. They'll put on there, and it's supposed to basically burn their skin off, and have the lesion fall off. It'll form what's called an eschar or a scab, and it'll just fall off. But these people will use it, it doesn't change. And then this one lady in this picture, she used it on a spot on her forehead and on her nose, and she used it either too much or so long it ate away into her cartilage. As you can see her septum. But when the eschar fell off, it was like her nose, inside of her nose. It's like, you'd be amazed how many people that would use the black salve and it would never go away, but they kept using it till their BCC or their SCC got so big before they came in. And so this is the benign one, the seborrheic keratoses. Okay, you could look at family members, yourself maybe, or friends that have these. These are very benign. They're common, very common. I've had a couple of these. I felt like with my parents, they have them.
Are these what people call liver spots?
No, those are probably more the lentigos, solar lentigos. But these are kind of raised, they're superficial, kind of look warty looking. Usually around the age of 40, you'll start developing them, and then as you get older, they just start growing. We used to call them in PA school just stuck on barnacles, because all of a sudden, it would just appear, out of nowhere. And you're like, where did this come from? And then you think, oh my God, it's so fast growing, I'm going to die. But if you see them and look at them and feel them, you'll know an SK versus a bad cancer. Most often you see them on the trunk, and then you can see one on the temples. One girlfriend of mine, we did the Race for the Cure, and I hadn't seen her in a while, and she showed up that morning, and she had one stuck on her temple. I swear I could have sworn she had a melanoma. It was huge, and she goes, all of a sudden it just appeared. And they got irritated because of her sunglasses. She'd wear them on and off. And I was like, oh my God, you get that taken, get it taken off, take a look at it, but it ended up being that. Signs and symptoms. So they vary in size. Some of them are really small, some of them can be bigger, some are more raised than others, but they all have this velvety texture to them and a warty look to them. And like I said, it's stuck on appearance. So think about a boat, the barnacles that are on the side of a boat that kind of form. That's what I think of SKs. And that's how we were taught. We were taught as stuck on barnacles. And when you see them, and you see people have a lot of them, like, does look like a clinical inside of adult. But then you can also have some people like these, if you get large, multiple ones at one time, they may be associated with an internal malignancy. And I never really could figure out how to pronounce that. So lesser Trellat sign is what I'm going to say it's called. So these are SKs. Anybody see them on their family members? So if they come to you and ask you, am I going to die from this? You can usually reassure them that they're not. But see how the ones on the right, lower right, are kind of flesh colored, not quite as dark as the ones up top. So the one on the far left, you could, the differential there would be a melanoma, right? But if you feel the texture of it and look at it, it looks more like a warty mole. So this is the one that a guy I was talking about that had maybe a possible associated with internal malignancy. Lots of them, they're bigger in size. Again, how do you diagnose these? Usually clinical experience and physical exam. A lot of times you really don't need to remove these unless they can become irritated, and if they feel like that one, my friend, big giant one on their forehead, I don't want it there. So cosmetic reasons, you can remove them. A lot of times people get them on their backs, right by their bra strap. A lot of times some will get it on their necks, where a necklace lies. So those are reasons why you would take them off. And you can just use liquid nitrogen to remove these as well. So basal cells. These are the most common types of skin cancers, most common type in general. You'll see a lot of these. These are slow growing and they tend to not metastasize, so that's the good thing about basal cells. These things can grow for 20 years. And believe it or not, people let them go that long. When I would work in head and neck, you'd see these things come in, and this man will have one giant one popping out of his ear and has been there for a year. But it's ginormous, it's blocked off his whole canal. Or you'll have one that's on their scalp that has been there for years and is ginormous. And you just think, is your family nut? You might want to get that taken. Someone look at that thing. But they do. They let him grow and grow and grow. They put salve on it. But the good thing is, if you're to choose one, you could use a basal cell because they tend to not metastasize. 85% are on the head and neck, just because of the sun exposure. But the only thing is, like I said here on the first slide, it doesn't metastasize, but if you leave it there long enough, it can cause tissue destruction locally. It can eat through the bone, the cartilage. It can get bad, or it can just be really destructive. So again, usually Caucasians, fair-skinned, average lifetime risk is 30% in Caucasians that you'll get one. One of my classmates, he's very fair-skinned. I used to call him the golden child because he had blonde hair, blue eyes, and was the smartest in our class. But he ended up with a basal cell, and he's not, probably in his mid-30s. He got one on his nose, right beside his nose. But he had a Mohs procedure. But now that he's had one, he has a higher risk of getting another one. Again, males are more common than females because all of this is the same pattern. They're out in the sun a lot more than women are, or have had been working out in the fields and stuff like that. Risk factors for BCCs, long-term sun exposure. Again, if you're Caucasian, Fitzpatrick type, prior BCCs. You can also develop a basal cell from previous trauma or surgery, just because of changing of the cell lines there. And then something called xeroderma pigmentosum. Did y'all learn about that? So that's just I think it's a genetic disorder where you can just be out in the sun for literally 5 minutes and they'll have a massive sunburn. So basal cells, the basal cells lie in the very lowest level of the dermis. That's why they're so slow growing, because it takes it a long time to grow up to the top of the surface of the skin. There are 5 major patterns. It's nodular, superficial, micronodular, or infiltrative, and then morpheoform. But the most common you guys will see is nodular and superficial. Again, we already talked about where they most commonly occur on the head, face, and neck. And then periocular, we would see these a lot. You'd see in the elderly that have it on their lower canthus. You could see, because they'll come in, their eyelid will be drooping because the cancer is pulling down their lower eyelid. Because, you know, a lot of times when men who do wear caps, it doesn't cover their nose, their ears, their lips, and a lot of times it's underneath the eye. That's why you start to wear sunglasses too. So nodular. These are the ones that you guys will see most often. These are the always on the board. It's a pearly white nodule with telangiectasia. That's how you would describe a nodular BCC. Sometimes they can have a central ulcer, so it kind of looks like a squamous cell, but they usually kind of have rolled edges and like almost like a little crater in the center. But again, once you start seeing them, you'll be able to recognize them easily. So this is what a BCC looks like. I was like giggling, I'm like, look at all, they're all on white people on the pictures. But see that pearly look to it? The top right one really kind of shows that at the about 12 o'clock position, you can see that pearly white, and then all the little telangiectasias in them. So that's commonly the sign of a basal cell. Now the upper left one is just, you can barely see the telangiectasia, but they're there, and it still has that pearly sheen to it as well. And that bottom one is more of that crater rolled edge that you could almost, you know, think it could be a squamous cell. Here's some bad eye ones. I didn't see upper lid as often. I would usually mainly see lower eyelids or medial canthus right there closer to the eye on the nose part. And the second one are superficial basal cells. So these are usually just on the, confined to the dermis, and usually on the trunks or the extremities. These are usually your younger persons. They are slow growing and they grow out peripherally. They usually have a scaling plaque, so it kind of looks like psoriasis or eczema. Would you guys have had your eczema and psoriasis lecture, right? So see, can you see how those would look like the psoriasis or eczema patch? So what you would do is, you know, you would just kind of watch it, have a patient, you know, look at their risk factors, you know, and determine whether or not you want to take a biopsy of that, or if it continues to grow and get bigger. Eczema patches usually stay about the same size, and it's more excoriation. If they don't itch, it's probably not eczema. Remember, because eczema is the itch that keeps on itching. The scratch, you keep on scratching. I can't remember. But yeah, especially the one on the right. So if you saw something like that, even though it could be in your differential, most likely it's not, because with this eczema or psoriasis, you'd have more patches, right? And then morphiiform basal cells, these are kind of yellow and waxy. They almost look like a fatty deposit on the skin. They still have a little bit of the telangiectasia in them. These don't really ulcerate. They're usually firm and flat. Again, you really have to feel these than see them. So see how it's really kind of flesh color. The one above the eyebrow gives you more of that yellow look to it and a waxy appearance. But the one on the nose, I think, also has that one. The one on the forehead upper left almost could look like a ringworm, you know, depending upon if it is actually red, because it has that central ulceration. And then the infiltrating basal cells. So these are the ones that I would see. These are the ones that are big and grow, and they just grow and grow and grow. And most of the times, like I said, they've gone in and it's already eaten away at their nasal septum, their cartilage. And these can infiltrate into the nerves and the tissues. So like I said, it's more locally destructive. And in children, associated with the basal cell nevus syndrome. Look at that. Believe it or not, we see a lot of those show up. Actually, I bet you this one is probably a mixture of a basal and a squame, just because of how bloody it is. This one, we see a lot of these too, because they would invade their eye. And so they'd have to have an enucleation, you know, when, like Dr. Moreau, she would do these, because it's invaded into their local eye tissue. And their nose too, you have to remake their nose. See, half of his nose is gone. Then we have something called a pigmented basal cell. So what do these look like? Melanoma. So they're kind of hard to see. These are more commonly in your people with darker skin and darker eyes. But this one I would definitely biopsy on both persons. Not saying, you know, melanin isn't always bad. You can have the amelanotic ones, which we talk about later, which is even worse. Another subtype is a cystic, so this one is a little bit more round, more smooth than a nodular basal cell. It still has that appearance. You can kind of see there close if you look. There's some telangiectasia in there. The basal cell, the nodular basal cells, I feel a little bit more firm. If you touch them and put your finger on them, it's a little bit harder than the cystic ones. And that's what we talked about earlier, the nevoid basal cell carcinoma syndrome. One thing really you need to know that it's a, you know, it's autosomal, rare, dominant, but it has multiple BCCs at birth or in early childhood. And these are all the differential diagnoses that you can think of how some of these would look. So, you know, when you're looking at a lesion, you want to think in your mind, okay, this is definitely a BCC, or maybe it could be all these other things. So in your mind, you look at the age of the person, their history, how long it's been there, have they had them before. Those are all the things that you need to ask them to help you narrow your differentials. But these are all the things it could be. Because I can see how a small basal cell could look like a molluscum, right? But usually the molluscum are going to be in who? Kids. So unless they have some rare genetic disorder, then most likely it's going to be a molluscum if you see it in a child. You shouldn't see molluscum really in male or an adult unless it's like an STD, which I've seen some of those. And then sebaceous hyperplasia. Have y'all talked about those? So sebaceous hyperplasia, and you may see them in, I know my mom has them, I think I've seen them. So they're just kind of small little bumps usually on the mid-face. It'll look like a pimple, but really not. But if you took a little 11 blade and nicked it, and take a little Q-tip, and you'd be able to extract it out, it's just a little pocket of sebum. And usually people have them all over their face, but we would treat them when I was a student. They would come in and we'd touch it and feel, and it's like, oh yeah, that's a sebaceous hyperplasia. So we take a 11 blade, nick it, and sure enough, push it out, and there's a little white little thing that comes out. But those are benign. And I can see how a cystic one can kind of look like an epidermal inclusion cyst. And so what do you do when you see one of these people and you think it's a basal cell? You would take a biopsy. You can either do a shave biopsy or a punch biopsy. You guys have your biopsy lecture yet? And last year we did a little PBL, which was kind of fun, the students enjoyed it, but I think we'll do it in capstone. You'll do punch biopsies we did on oranges, because there's multiple layers, you know. But a punch biopsy, have you all seen one, what they look like? You know, it has a little really sharp metal knife or punch, and it goes up to the hub is what we call it. So when you're taking a biopsy, you take it and you twist it down to the hub, and then you take that out, and then you pick it up with your pickups and you snip it off. But that's how you do a punch biopsy. In a shave, you would use I think it's a two-sided blade, and you just kind of slide it up along the dermis. Generally for basal cells, you don't need any imaging unless, again, they're large and you suspect local invasion. And then, or if you're going to have surgery. So our patients usually got CT scans because we're planning for surgery, so we know the extent of the local destruction. And then this is just a little side. When you guys get reports on pathology, like you go and send something off for biopsy, you'll get either undifferentiated or differentiated. But an undifferentiated is usually just a solid BCC. Differentiated means it's got other cell lines within it. Again, treatment, usually surgical excision, you want to get that taken off. Now, a lot of times, depending on how small it is, you can do Mohs procedures. So a lot of times, since they don't metastasize, you can do Mohs where they, basically, you'll see a Mohs surgeon, which is usually a dermatologist, and they will cut out the lesion, and they'll keep cutting around it, and then he will look it under a slide and see if there are still cancerous cells within those. And then if there is, he goes back, cuts a little more, cuts a little more. So unfortunately, some of the basal cells, they may be small, but they've got infiltrating cells around it, and so you have to get clear margins. But a lot of times, you can have a small basal cell, or like it's sitting right there, and your defect can be like this big. And so those people, you can't just leave it with a giant open wound like that. You have to send them to a dermatologist, either a plastic surgeon or a head and neck surgeon, somebody to put a graft on it. And then the skin graft will just kind of lay on there and heal and rest over. And I don't know if you guys talked about skin grafts. Did we talk about that in head and neck? So I don't know if you've ever seen how they harvest a skin graft. It's like basically this machine that looks like a cheese grater or something. And they take a piece off of the thigh, usually, a small square. And it's a very top layer. And so they're left with basically like a bad skin rash on their, or rug burn on their thigh. But tons of times what hurts worse is that defect on their thigh than the actual surgery on their face. Because you think about it, when you get a rug burn, how bad that hurts, or road rash, how bad that hurts. So imagine if they took a whole strip of it off your leg. And then it dries and crusts up, and then it pulls and tugs and you move your leg. But basically, they take that piece of skin, they sew it to the defect, okay, and they trim it so if it's a round defect, it's going to be a round skin graft. And then they put a bolster, which basically is, they use like that gray spongy stuff in surgical sponge, or they will use xeroform gauze that they create into a little flower, and they use that as a bolster. So they sew that to the defect, to the skin graft, into their skin. So they come in, they've got this flower thing sticking on their head. But basically what that bolster does is that it keeps that skin graft in place so it doesn't move. So usually they sit with the thing there for about a week, and it gets all nice and crusty after surgery, and then they would come in and see me, and I would remove that bolster. But what you have to be careful about when you move that bolster is not to pull the skin graft underneath there off with the bolster. So you have to be really gentle when you move that off. But usually it's amazing. So the downfall of you all who are fair-skinned is you get skin cancers. But what's nice is when you heal and get skin grafts, you can hardly tell you have it. So it's a catch-22, because you don't scar as badly. And you can do the same thing, the electrodesiccation and curettage, and then radiation therapy for some larger tumors. You can radiate them, and then the Aldara and the FU cream. And there's a new one, it was called Evelyn, so it's an oral chemo agent that you can take as well. I had some patients that were taking this because they would have multiple BCCs, and so they were given oral chemo to help prevent new ones. So our patients who have basal cells, they'd be seen for at least 5 years, whether it be with us or with a dermatologist. Depending upon, we saw them if they had the big giant ones, we'd see them more often. But a small basal cell, like my friend, he probably should be seen twice a year. So these are my patients. I left them off your slide. So this lady had a really bad basal cell on her right nasal wall and mid face. So we had to do what's called a oh gosh, why can't I think about it? We take a flap, forehead flap, and we basically rotate that around and cover her defect. And so she has this trunk that kind of just sits there. It's connected from her forehead to her nose. But it has like a little tunnel, so you literally see a piece of skin, like, and tissue hanging right there. She has it on there like that for about 4 weeks. And she has to make sure it stays nice and clean. And then she has another surgery at 4 to 6 weeks, and they basically clip this off, because they want to make sure this is supplying vascular supply to the nose. So then we clip this off, sew this up, and sew this up. This isn't the best one. There's one man that had it. He had a large defect on his nose. I wish I had taken pictures, but I couldn't find it on my iPhone. But you could never tell he ever had surgery. He healed so well. I mean, he had the whole paramedian forehead flap, but his nose looked amazing. Hers was a little bit rougher because she must have had a larger defect. And sometimes they actually have to do 2 flaps because they lose so much underneath that you have to create a tissue underneath the face. Okay, squamous cells. Any questions about basal cells or AKs, SKs? So that's going to be your bread and butter if you're in family practice. Those are most things that you'll see. And you will see these as squamous cells as well. So the first thing we're going to talk about is squamous cells in situ. So these are they're still cancers, but very early cancers. Just kind of like when we did the breast cancer, you know, the breast cancer in situ, it's the same thing. So again, it's called Bowen's disease, and I'm not sure why they call it Bowen's disease, but you can also call it squamous cell in situ. But it's superficial squamous cell. Again, usually sun-exposed areas, but you can have them in any location. In other locations, it has a different name. Signs and symptoms, it can be one single lesion, you can have multiple lesions, a scaly patch that doesn't heal. So that's the one thing about squamous cells, is if you have an ulcer or sore on your face, your arm, your skin that doesn't heal, you need to think about a squamous cell. So, you know, a lot of men will say that, oh, they keep cutting themselves shaving, but actually they just keep re-irritating the squamous cell that just won't heal, or it crusts over, you pick at it, it bleeds, and it crusts, and then it crusts back over, you pick at it, it bleeds, crusts back over. So those are things you want to think about for squamous cells. These kind of slowly increase in size. They can itch, but not always, and they're generally not painful. So these are usually red or brown in color, and they're scaly and crusted. So again, a lot of scaly, crusty things in dermatology, right? Everything is crusty and scaly, it seems like. But these look like thin psoriasis plaques, dermatitis, or even a ringworm infection. How do you diagnose this? Probably you just take a biopsy of it. Take a little small chunk of it. That one at the bottom right definitely looks like a psoriasis plaque. And again, treatment's about the same. You'll see this commonly, I guess, when you have your derm lecture, I guess. You're going to be telling, did Dr. Latassi give you guys an outline, or what does she normally give you guys? The packets? Okay. But you'll see the Aldara cream, 5FU, she talks a little bit more about that probably, and then cryotherapy was just the liquid nitrogen. And all your patients, you want to educate them on sun care prevention. So then you have something called erythroplasia of Kara, which is Bowen's disease of the glans penis. So this is not a sun-exposed area, at least I would not think it would be. But this is probably rare, you probably won't see it, or you might see it, but these are always in, most of the time, in uncircumcised men. And these can progress to an invasive squamous cell carcinoma. So it's very important when you see something like this, if someone has a sore on their penis, comes in complaining about it, you take a look at it and then you think, oh, he's uncircumcised, so this would be on your top differential. But these will complain of redness, crusting, may itch, may bleed, may hurt. So a lot of times these can be, they can look more like a yeast infection, you know, just because it gets red and raw in an uncircumcised patient. Or you can have difficulty retracting the foreskin. Do y'all remember what that term was? When it gets stuck? Or the opposite? Paraphimosis, right? God, it seems like a long time ago since we did that. Okay. So physical exam, you can have single or multiple lesions, usually non-tender, slightly raised, papules or plaques on the glans penis. And sometimes you can also have it on adjacent tissue as well. Here are some differentials when you think, when you're looking at them, what they could be. So you see that top right, how you can almost confuse that with candidiasis, because it looks red and angry like candidiasis, and also has that white discharge appearance to them. The one on the left, see that scaling redness? That almost could look like a psoriasis too. And the bottom one, I feel like, if you saw that, you think, oh, that's not right. In an uncircumcised male. And how do you diagnose these? With biopsy. But you get to the biopsy of it. And then you can treat them with the same treatments that we've already discussed. Sometimes they will do surgery, so they can do a partial lancectomy. So those who have more advanced disease, but they always want to try to do some type of penile sparing. You can also do a circumcision, and then you can do skin grafting to that area as well when you do a partial lancectomy. And then squamous cells. These are the ones this is the one you don't want to have. Because the squamous cells are they're the second most common skin cancer. But with these buggers, they like to metastasize. So remember in our head and neck, all my bad head and neck cancers, what were they? Squamous cells. And these have a higher risk of metastases. So when you have them, when you see them, especially up on the top of men's head, you want to treat them, get rid of them, because then they can metastasize through the lymph line. And that's why maybe they had one that regressed, and then it goes into the lymph line, and they show up with a knot in their neck. That's how that usually happens. Again, sun-exposed areas. You can also develop squamous cells in places that had trauma, prior radiation, surgeries. If you have a scar, you can have some that come from scars. Any areas of chronic irritation, you can develop a squamous cell. So again, risk factors, UV, radiation, light hair, light eyes, same people you worry about, outdoor occupation. We would see a lot of these immunocompromised, those who've had cancers, certain types of cancers that have chemotherapies. Some of the chemotherapies can put you at a high risk of getting skin cancers. We'd see that a lot, is they develop skin cancers from their chemotherapy treatment. Again, same locations, usually scalp, back of the hands, top of the ears. So when you tell your dad to cover when he goes golfing, we mean not just a ball cap, but a nice floppy hat. Either one out in the yard, mowing the lawn, those are the kind of, because you want good coverage. Again, males, more common than women. Precursors, we talked about that, AKs, and then you have those cutaneous horns that picture I showed you. Signs and symptoms, again, that non-healing sore. So if someone comes in and says, I've got this sore that just won't heal. It keeps crusting over, I pick at it, it bleeds. Then you need to start thinking about a squamous cell. Because you will hear that a lot in practice. You'll hear, I've got a sore that just won't heal. Okay? These are a little bit more shallow. They have more of an ulcerative look to them. They're not nice and round and pearly. And they can be scaly and thick as well. So see how more these look more aggressive than your basal cells? Usually these are the ulcers and the sore. You know, in PA school, they only taught us like on the shins. For some reason, I remember my derm lecture it showed us a picture of a SCC on a shin. You can have them because, think about it, girls when we lay out, what do we want to get tan? Our legs. And then our arms. And so the one that they showed us was on the shin. Or I think it was a story, I think it was a biker, like a motorcycle person that would ride on his bicycle, and he thought he got burned by the exhaust pipe, but it wouldn't heal. Come to find out he had a large squamous cell on his shin. And so the lower lip one, I had a patient who had a lower lip squamous cell like that. They biopsied it. This tells you how fast they grow. By the time she came in for me for pre-op, for me to sign her paperwork, it had been maybe 2 weeks. It was on her lower lip and had grown into her inside of her lip. That's how fast some of these can grow. So then she will have a bigger defect on her lower lip. Am I scaring y'all till you never want to go out in the sun again? But the damage has already been done, unfortunately. So these things won't pop up till for another probably 10, 15 years. But A lot of times the damage has already been done before the age of 35. Again, like we talked about, these tend to metastasize. They tend to invade the nerves, lymph system. And again, the depth of invasion is very important with these because they can grow deeper down into the tissue than superficially. Highest risk for occurrences on the scalp, ears, lip, nose, and forehead. So the same differentials as you saw on the last list. And what do you want to do when you see one of these people? You want to take a biopsy of it. And I remember when I had to do my first biopsy, even as a PA student, I was real nervous. I don't like needles, so I was afraid I was going to hurt the patient when I inject them. Because it burns, you know, when you're injecting lidocaine to numb them up. And you want to do it to where, as Professor Hughes talked about how you blanch the lesion when you're injecting them, it'll turn bright white. And I was always nervous about doing them when they come in with them on the cheek or on their mid-face. Because I'm like, oh no, I'm going to numb up their facial nerve. They're going to become paralyzed. But if you keep it superficial, blanch it, take a biopsy, I mean, they don't feel a thing after the initial coat. But take a biopsy of it, send it off. CTs and MRIs, again, we mainly did it if they were going to have surgery to remove it. If it was a big one and it invaded deep, we would do it. But for small superficial ones that you guys see in the office, you can just do usually the dermatologist would do more like an ellipse excision. So staging, I know we kind of talked about it back in head and neck. It's the same type of staging. So with the skin cancers, they do the TNM, tumor, node, and metastases. So that's all you really need to know, because there's all kinds of other stage 1 to 4, depending upon the size of the tumor. If it's less than 2 centimeters, greater than 2 centimeters, you won't need to know that unless you work in dermatology or you work in head and neck. So just know that they do TNM staging to stage the skin cancers, because that's real important as far as treatment-wise, is you stage them first. Okay. With squamous cells, the highest features is greater than a 2 millimeter depth in thickness. So when you take a biopsy, on your biopsy results, it'll tell you how thick the tumor is. You know, because if you get down to the hub, you should get a pretty big chunk of it. So the thicker it invades in depth, it's the higher risk of aggressiveness of that tumor. Okay. Again, perineural invasion is always a high-risk feature, and then on the ear, and then the hair-bearing lips. And then staging is can be from 0 to 4. But again, you guys don't need to know the exact staging-wise, because I didn't learn it. It took me forever to memorize it when I worked in head and neck. Again, treatment, you want to take these all off with good margins. So usually with a squamous cell, I think they do, I can't remember, half a centimeter or 5 millimeter margins when they cut out around it. Again, just to get all the little cells that can be outside, or we call them cancer fingers. Melanoma tend to have more than squamous or BCCs, but again, you could do a Mohs surgery. Radiation, a lot of times our patients would have to have radiation after. And only times I really do chemo is if they've had metastatic disease. So normally it's excision and then radiation for squamous cells. Rarely, again, unless they've had disease other places. So our patients who had like a tumor in the neck usually take that out. They have radiation to the neck, but usually generally not chemo unless they have it somewhere else. Do you think that's a pretty big lesion on his eye? So he's old. He had multiple. This is the patient line. You can see on his face. So look how white he is, right? But look on his chin. He's had a flap there. His cheeks. He's all flat. He's had a graft there. So what he had there was he had a graft because he had what was hard for him is he had a skin cancer there, had a graft. Then he developed another skin cancer on top of that. So we had to make a bigger wide excision. Then, to top it all off, he's a horrible smoker. He wouldn't quit smoking. So what happens? You can tell by that skin graft, it didn't take. Because what you see is you see his skull. That center yellow part, that's his skull that's exposed. So we tried to clean off the graft and do all kinds of wound care for him, but I think eventually he had to go back and have another skin graft. I'm like, he's gonna run out of thigh, as many skin grafts as he had. But I would counsel him on smoking. Would he ever quit smoking? You know. So that's the risk you take with the skin grafts. If you cannot perfuse microvascularly from smoking, they're going to die. The skin graft's going to take. Now sometimes what we would do is he'd come in and we'd try to the little edges we would scrape with the curettage to try to get it to bleed and scar and kind of grow over itself. But I don't know that we'd ever cover all of that. I think we ended up, I can't remember if we ended up rotating some part of the back of his scalp around to cover that. We can do that too. There's another patient, he had a large defect above his eyebrow. So he had a Mohs procedure. So he came in to see us to get us to fix his defect. So yeah, a lot of times, look, I mean, I'm sure it was small to begin with, but the defect is big. And I can't remember, I think he had invasion of his, just right above his eyebrow. So you have to be careful when you put a graft in there or do something that it's going to lift his eye, you know. When he scars down, it'll lift it up. This is a squamous cell of the lower lip. His graft obviously did not take, but yeah, they took out the whole inner lining of his lip, tried to graft it. But you can see by his oral care that he did not take care of himself. He probably was a smoker, sun exposure, so he had both of those, you know, smoking, all the toxins from the cigarettes. And then this gentleman, he'd come in, he had to have 2 of them. So you could tell we had to try to fill the defect. It was a big one. So that's not his eyeball there. That's a paramedium forehead flap in the socket there. And so the one he had here is healing. So we tried it again because we used that one, the second one, because I think the initial one we used to align the cavity, because you can tell on the inside of the septum right there, his nasal wall, it's still exposed. And so when we'd come in, I'd have to clean out all that crusting right there at the front of that. So that was from his, I think that one was brought up from this side, because it's got hair. So I'm assuming it probably came from either the very back part of his scalp, or part of it might have been from his eyebrow. But I'd have to come in and I'd clean that off. He was a smoker too. But I never saw it initially, so I'm assuming he just let a lesion just grow and grow and grow until it ate half his face. Kaposi sarcoma, which I think we talked about in head and neck, right? So I'm just going to fly through this. This is mainly AIDS-related. There's 5 different subtypes. There's like African, there's one in Mediterranean people, but the ones that you would encounter are with your AIDS patients. So tumors on the skin or the mucosal surfaces. It was rare prior to the AIDS era. So usually Kaposi sarcoma is usually AIDS defining. So most of the times, by the time they develop these tumors, they have full-blown AIDS. And it's the most common type of Kaposi that you'll see in the U.S. And again, it's just HIV related. And it's caused by human herpes virus 8. So these are usually always associated with these tumors. Young males, homosexuals. Remember, so they're the violaceous macules or papules that are on the skin, usually on the trunk and the face. Like we said, AIDS defining. You can definitely tell the bottom one is an AIDS patient. He just has that cachectic look about him. You know, now with the treatments of AIDS and stuff like that, or HIV, I don't think a lot of them end up there like they used to in the early 80s and 90s, but basically diagnosing them, you take a history, full history of their operations, their sexual history, and then do an HIV test if they don't know. Surely by then they've known their HIV status, so then you would do their levels, their quantitative and qualitative levels. You want to do chest x-ray, EGD, colonoscopy, biopsy, just to look for any metastatic disease. A lot of this is in there just because I wouldn't even, so don't worry about the management of KS, because most likely you're not gonna treat it. Just be able to recognize it, okay? Because you'll get this again when we get into infectious disease. We actually talk about HIV. Okay, let's go take a break and then we'll finish this. Any questions about SK?